Good afternoon. Welcome to the webinar Peripheral Neuropathies. My name is Dr. Kazim Sheikh. I am a neurologist, a neuromuscular neurologist with long-standing research and clinical interest in peripheral nerve disorders. I moved to UT and Memorial Hermann about 3 or 4 years ago, and currently practice both at UT and Memorial Hermann. I am part of the Mission Neuroscience Institute. I see patients on outpatient and inpatient basis, and have a research lab which is focused on developing new therapies to help patients who have peripheral nerve disorders. What I'm going to try to do over the next 35 to 40 minutes is give you a broad overview of peripheral nerve disorders and tell you what do we do when a patient walks in with complaints of neuropathic disease. I'm going to try to explain to you how peripheral nerve structure is set up and functions and how its dysfunction causes symptoms that a patient feels when peripheral nerves are dysfunctioning. I'll briefly touch on the causes of peripheral neuropathies and also briefly touch on the management issues in patients with peripheral nerve disorders. As I said, this is going to be a very brief, broad overview. I am not going to discuss any particular disease in detail. We'll probably touch a little bit on diabetic neuropathies and discuss a little bit how to manage pain in patients who have peripheral nerve disorders. But then we'll have sufficient time, hopefully about 20 minutes to take your questions and address specific questions at that point. So, what are peripheral neuropathies? Any disease that affects peripheral nerves is called peripheral neuropathy. These disorders are not uncommon. They most commonly affect folks who are age 50 or older. There are studies that have assessed the prevalence of these disorders, and it's estimated about 2 to 3% of general population have some form of peripheral nerve disease, and in individuals who are older than 55, the incidence increases and is anywhere between 5 to 8%. I want to sound reassuring. Vast majority of peripheral nerve disorders are not life-threatening. They cause a lot of morbidity, commonly pain, but they are not life-threatening and they persist for a long period of time. This slide shows the anatomy of peripheral nerves. And the peripheral nerves consist of 3 different kinds of nerve fibers. There are motor fibers that function and control our voluntary movements, and they are shown here. These fibers typically have insulation or myelin around them, which allows them to conduct really rapidly. Then there are sensory fibers, and we tend to divide them into large and small. So the large sensory fibers are shown here, and the small sensory fibers are shown here. And the difference between these two types of fibers is the large fibers have insulation around them, and they serve the function of balance and ambulation, which occurs in us seamlessly. We never actually think when we are moving how the balance is being coordinated. These large sensory fibers play an important role in our balance and ambulation, whereas these small sensory fibers, which don't have any insulation around them, serve protective function. They protect us from injury, from things like pain, and from for example, heat or cold pain. Then the third set of fibers are autonomic fibers, and they control our heart rate, blood pressure, sphincters, sweating, sexual function, gastrointestinal motility. And in neuropathic disorders, all three kind of fibers can be affected to a different extent. Sometimes they are all affected, sometimes one type of fiber is predominantly affected. And in patients, when these different type of fibers are affected, then they can have different set of symptoms. For example, when small sensory fibers are affected, then patients commonly have pain, numbness, and tingling sensation. When large sensory fibers are affected, then patients complain of poor balance. And initially, patients notice this poor balance when they wake up at night time, and if the light is off, then they have difficulty really getting up and going around. The other time when this poor balance manifests is when they are taking a shower and they close their eyes, they feel that they are unsteady. Motor dysfunction can be reflected as a cramping sensation. Sometimes twitching of the muscles is noted, and patients also have weakness and atrophy of different muscle groups, particularly distal muscles in the feet tend to get affected first. The autonomic fiber dysfunction can cause symptoms such as diarrhea, excessive sweating. Patients can have sense of dizziness when they stand up quickly. They can have sexual dysfunction. Areas of body can actually stop sweating. They can develop constipation. Sometimes they develop this sense of fullness after they eat because of dysfunction of autonomic nerve fibers. When we see a patient who has peripheral nerve disorder, we sit and talk with them, take the history, and then examine them. There are several features in history which are listed in this slide that are helpful to us. It includes conditions that put ones at risk of developing some of the neuropathic conditions. It also asks them about exposure to substances that can cause toxic neuropathies. There are subset of neuropathies which are hereditary in nature, and we try to get a family history from that perspective. Then we examine the patient, and we have testing bedside testing that checks out these different sensory fibers, motor fibers, and also the autonomic fibers. And some of you who have this problem and have seen the doctors for this would know how some of the things listed here are done in a doctor's office. Once we have seen a patient we suspect who has a neuropathic disease, then we do ancillary testing to confirm our diagnosis. And the test that is most commonly done in patients who have peripheral nerve disorders is called nerve conductions and EMG. There are two parts to this test. The first part is nerve conductions, where different sensory and motor nerves in arm and leg are stimulated and recorded. And then there is a second part of this test which is focused on muscles. It's called EMG, where a needle is inserted into different muscles. These two different parts give us different information. The EMG part predominantly gives us information about damage to motor nerves. So when a motor nerve fiber gets disconnected from muscle, then the muscle develops features that indicates to us that if this process is happening actively, or it happened previously and at this point is not active, then it also gives us the distribution of nerve fiber damage as we sample different muscles. Whereas the nerve conduction studies allow us to tell if the insulation part of the nerve fiber is affected, or is it really the axon part, which is equivalent to the copper wire. So usually use analogy of electrical wires as being equivalent to nerve fibers, that they have insulation around them, and then they have copper wire which is equivalent to the axon, and axon is the part along which the nerve impulses travel back and forth, either towards the spinal cord and brain, or they actually travel peripherally from spinal cord to the muscle. Insulation and axon part can get affected. We talked about small sensory nerve fibers which don't have any insulation. These type of fibers are not tested by nerve conductions and EMG. Over the last 10-12 years, a new technique has emerged which allow us to actually check out these fibers quite sensitively, and now we do skin biopsies, and I'll show you one of these skin biopsies as we proceed. We use them to make the diagnosis of small fiber neuropathy. We rarely do nerve biopsy in a specialized set of patients to look for inflammation and specific disorders that are not diagnosed by nerve conduction skin biopsies. Then there are functional testing of sweat and sensation, which are less commonly used. They are called QSAT and QST, which we sometimes used in specific patients. And sometimes we do imaging of the nerves, and there are various MRI techniques and CAT scan techniques that are used, sometimes to actually look at the nerves directly, sometimes to exclude the possibility of lower back disease causing neuropathic symptoms. So all of these techniques, we have them available at UT and at Memorial Hermann, and we use them in evaluation of patients who have neuropathic disorders. This is an electron micrograph showing normal peripheral nerves. This is from a patient, and what you see here are these large fibers. Now these are nerves that are cut in cross section. These are the myelinated fibers I was talking about. They have this black insulation around them, and inside it is this axon. This is the conducting element of the nerve fiber. And you can see then there are these small structures which are right here. The arrow actually is pointing them, and you can see they don't have any insulation around them. They just have this white small structure which is axon. So these are the unmyelinated fibers, or the small sensory fibers that we see, and some of these are autonomic fibers. And when we do a nerve biopsy, we actually can look at different kind of nerve fibers and tell which type of fiber is affected, and whether this insulation part or the axon conducting element is predominantly affected. Some of the other things that we can see on these nerve biopsies include inflammation, deposit of materials which are not normal constituent of the nerve, such as amyloid, can be seen. So these nerve biopsies in a small subset of patients are extremely helpful. As I said, that for small fiber neuropathies, now we use skin biopsies for the diagnosis. And this picture on the right side of the screen shows you a normal looking skin which have these epidermal nerve, small epidermal nerve fibers going up all the way to the surface. As I said, these fibers are really important in protecting us from extraneous injury, and in disorders that affect small fibers, we have loss of these fibers. So typically we do a nerve biopsy and we count the number of nerve fibers per millimeter in the epidermis, and in patients who have small fiber neuropathies, the density or the number of these nerve fibers tend to decrease over time, and there are norms that we have for normals, and we use that to make the diagnosis of small fiber neuropathies. Now, moving on to the causes of neuropathy, there is a huge number of conditions that are associated with neuropathic disorders, and I'll actually try to list all of them and touch on these. But in about 25 to 50% of the patients, we do not come up with a cause of neuropathic disease. These are called idiopathic or cryptogenic neuropathies. So it's not uncommon for patients who have chronic neuropathic conditions that a cause is not determined, and it's not infrequent that I see patients who do not have a cause determined for their neuropathy to be seen in my clinic. So the commonest cause for peripheral neuropathies is diabetes. This is both in US and other developed countries. My philosophy is that any patient who has neuropathic disease should undergo specific testing to evaluate for this condition. I typically use a 75-gram 2-hour oral glucose tolerance test. I do not use a random blood glucose testing or hemoglobin A1C, which is a marker of glucose levels over a 2 to 3 week period, which some physicians like to use. I really do this specific testing, and American Diabetic Association has approved and favors use of this test to make a diagnosis of diabetes. In patients who have other reasons to have neuropathy, it still is a good idea to do this test because in these patients, if they have coexistent diabetes, then it's a comorbidity and it can actually aggravate their neuropathic condition. Therefore, I tend to do this test in all patients I see who have peripheral nerve disorder. The prevalence of diabetic neuropathy varies quite a bit. It depends how one determines this in patients who have diabetes. If one uses clinical examination, then you pick up less number of people who you call as having neuropathic disease. But if you use ancillary testing such as nerve conductions, then the prevalence actually increases significantly. There are studies that show that over 50% of patients who have had diabetes for over 20 years will have either symptomatic clinical neuropathy or subclinical neuropathy that can be determined by either clinical or ancillary testing. There are several patterns of diabetic neuropathy that one sees in the clinic. The commonest of these is called distal symmetric sensory neuropathy. In these patients, the symptoms start in feet and they progress upwards. Typically, these are sensory symptoms, numbness, pain. As the symptoms progress and reach the knees, then the fingertips become involved with the sensory symptoms. These patients tend to have mild motor fiber involvement. It's a predominantly sensory neuropathy. This is an important cause of diabetic foot, by which I mean that these patients can have injury to the feet because of neuropathy and associated vascular and other complications of diabetes. They can develop ulceration. They can develop what is called as Charcot joints, which are really minor fractures of the bones in the feet because of stress, and that causes a lot of mischief in these patients. Autonomic neuropathy is also not uncommon in patients with diabetes. It's not uncommon that these patients complain of sexual dysfunction. They also can complain of early satiety, or they can complain of that they get too full after they eat, and this reflects abnormal motility of the gut, particularly of the stomach. These patients can also have dizziness, particularly when they stand, and they can have abnormal cardiovascular reflexes which affect the heart in several different ways. Because of autonomic nerve fiber involvement, sometimes patients can have silent myocardial infarctions. That's why in patients who have diabetes, one really has to do additional testing like EKGs and cardiac enzymes once they have non-specific symptoms. One has to be on the lookout to look for myocardial ischemia, because they sometimes do not develop typical symptoms of heart disease. Another form of diabetic neuropathy is called amyotrophy, where the thigh and the proximal leg muscles get affected either on one side or the other side. In these group of patients, it is not uncommon that they have significant weight loss, sometimes up to 50 to 100 pounds. This condition mostly recovers on its own, but good glucose control is extremely helpful in having the nerves repaired. Diabetic patients also can develop what are called as mononeuropathies, meaning a single nerve gets affected and they do not have diffuse involvement of the nerves. So cranial nerves that control extraocular muscles or the face itself can get affected. Rarely, diabetics have what are called as truncal neuropathies. They can have pain and tenderness either in the chest or abdominal wall, and that confuses a lot of physicians, and sometimes these patients do end up having unnecessary abdominal surgeries because the surgeons actually are exploring the abdomen because of pain that is not diagnosed or localized to a specific viscera in the abdomen. Then entrapment neuropathies such as carpal tunnel syndrome are also quite common in patients with diabetes. The pathogenesis, how the nerves get affected, is quite complex, and I'm not going to get into that, but metabolic factors, then microvascular ischemia, and autoimmune factors tend to play a role, and cumulatively these abnormalities cause nerve damage and diabetic neuropathy. There aren't specific treatments that can reverse or enhance nerve repair in patients with diabetics. We tend to encourage tight blood glucose regulation in these patients because this prevents or delays the onset of neuropathic disease in patients who already have neuropathy. If the blood glucose is tightly regulated, then it slows the progression. Foot care is extremely important in patients with diabetes because they are at risk of developing Charcot foot, as I mentioned, and of ulceration, sometimes developing gangrene. So having competent podiatric care is really helpful. Examining the feet every day, avoiding high impact exercises such as running is not a bad idea in patients who have moderate to advanced diabetic neuropathy. Pain management is another important element of management of these cases, and I'll actually talk a little bit more about that at the end of this talk. And then there are various medications and interventions which are used to help autonomic features of diabetic neuropathy. Other metabolic neuropathies include various disorders that can affect other endocrine organs and kidneys. In patients who have renal failure, they can also develop diabetic neuropathy. For these conditions, typically we use blood and urine testing to make the diagnosis. Then there are a set of nutritional neuropathies that we see in the clinic. They could be because of deficiencies of various vitamins and minerals that are listed here. It's important to know that if one takes excessive amount of vitamin B6, then it paradoxically can cause sensory neuropathy. Sometimes patients tend to take too much vitamin B6 just as a caution, if you're going to take vitamin B6, I typically recommend patients not to take more than 25 milligrams a day of vitamin B6 because if one takes higher amounts over a longer period than that, paradoxically can aggravate neuropathy or even cause neuropathy. Alcoholism because of vitamin deficiencies and because of direct neurotoxicity of alcohol can cause neuropathy. Celiac disease is really gluten allergy. It also can be associated with peripheral neuropathy. And in about 2 to 3% of patients who undergo bariatric surgery, they also develop a neuropathic disease. We do not really understand the pathogenesis of this problem, but we suspect it is because of malabsorption of nutrients that are helpful in the maintenance of nerve. Typically, we do blood testing for the diagnosis of these neuropathies and in patients who have celiac disease, we start with antibody testing, but sometimes they require biopsy of the small gut to make the diagnosis. Then after diabetes, the second commonest cause of neuropathic disease is toxic insults. And the toxic insult that we see most commonly in clinic are chemotherapies used to treat cancer. And some of these drugs are listed here. Then certain metals, insecticides, other toxic industrial agents, all of these can cause neuropathic disease. There are a list of medications that are listed here under other drugs which also can cause neuropathy in susceptible individuals. The diagnosis of these neuropathies is by history, blood, and urine testing. Infections is another important cause of neuropathic disease, and if recognized, some of the infections are treatable. In US, Lyme and HIV probably are the two commonest infections that are associated with neuropathy, but worldwide leprosy still remains the commonest cause of neuropathic disease, particularly in Asia and Africa. We have rarely seen leprosy in Texas, but it is not a common occurrence in Texas or US. Some of the hepatitis viruses, particularly C, can be associated with neuropathic disease. Diphtheria used to cause a specific pattern of neuropathic disease that affected the pharyngeal muscle and swallowing. It's not a common disease after the regular use of diphtheria vaccine. The diagnosis of these infectious neuropathies again is established by blood, CSF, which is the spinal tap fluid, and bacterial tests. And sometimes we end up doing skin or nerve biopsy, particularly in cases who have leprosy, to make the diagnosis. Immune neuropathies is a small subset of peripheral nerve disorders. They are very important to recognize because it is among the minority of disorders where we can do something, where we have treatments that can affect the course of neuropathic disease. The two commonest immune neuropathy, one of which is monophasic and seen only in acute setting, is called Guillain-Barré syndrome. The other one is chronic and is called CIDP. They are commonly overdiagnosed, particularly CIDP. The incidence of both these neuropathies is about 1 in 100,000. So it's not uncommon for me to see patients in my clinic who come for second or third opinion for CIDP because as I said, these conditions have treatments, so it is not uncommon that physicians would label neuropathies which are either idiopathic or they have other cause of etiology that they would start treating them with one of immune therapies, and when these patients do not respond to those treatments, it's then when they start seeking other opinions to see whether they really have the disease or not. The diagnosis of these conditions require electrodiagnostic testing, commonly spinal tap, and occasionally a nerve biopsy. Connective tissue disorders such as lupus, rheumatoid arthritis, and other related conditions are also associated with neuropathic conditions. Sometimes this autoimmune process or connective tissue process extends and involves the blood vessels which also supply the nerves. It's called vasculitis. It's a serious life-threatening condition, but it's treatable. So recognizing this in the context of connective tissue disorder is important, and we commonly make this diagnosis by blood testing and nerve biopsy, particularly if vasculitis is suspected. Besides nerve, we tend to also include muscle in biopsy because sometimes you can see the blood vessel involvement in muscles as well in this condition. Then there are hematological disorders that are associated with the neuropathic disease. There are these conditions called monoclonal gammopathy of unknown significance, where some of the plasma or B cells make an abnormal IgG or IgM antibody, and about 10% of patients who have neuropathic disease can have MGUS or an associated hematological disorder listed here. The Waldenstrom macroglobulinemia and multiple myeloma listed here are much less common, and rarely these patients can develop a deposition of these abnormal proteins in the nerve, causing what is called as amyloid. Rarely lymphoma can be associated with the neuropathic disease. The diagnosis of these conditions is established again by blood, urine, and imaging studies. Sometimes bone marrow biopsy is required to make a diagnosis of Waldenstrom macroglobulinemia and multiple myeloma. Neuropathy is seen also in the setting of cancer. As I mentioned previously, a number of chemotherapeutic agents that are used for the treatment of cancer can cause neuropathies, and this toxic neuropathy is really the commonest variety that one sees in patients who have cancer. Rarely one can develop direct involvement of nerves in patients with advanced cancer, and this is one of the causes of severe cancer pain that one sees in terminal or pre-terminal patients who have metastatic cancer. Rarely patients who have cancer can develop what is called as paraneoplastic neuropathy, where we think that the cancer triggers autoimmunity, which then affects nerves. The diagnosis of these conditions is made by history, by testing for immune markers, then doing scanning, for either the underlying cancer or for malignant disease. Sometimes CSF studies and rarely nerve biopsies are done for the diagnosis. Entrapment neuropathies simply reflect mechanical compression of different nerves. As most of you are aware of carpal tunnel syndrome, it just reflects mechanical pressure on a nerve called median nerve. At the wrist. The other common entrapment sites are at the elbow, and then there are entrapment sites over the fibular head that is around the knee. There is a tunnel that runs on the inside of the foot, which has a tibial nerve, and they can these nerves can be entrapped in these different areas. The common causes that are associated with these mechanical neuropathies are again diabetes, hypothyroidism, amyloid, and some hereditary neuropathies, and again you can see these in association with rheumatoid arthritis. The diagnosis of these conditions require the usual evaluation and blood testing. There are a large number of hereditary neuropathies that one sees in the clinic. The commonest of these are called Charcot-Marie-Tooth. There are now about more than 50 genes that have been identified which cause these neuropathies grouped under Charcot-Marie-Tooth disease. About 10 to 12 of these genes are available for commercial testing. The others are available only on research basis. Then there are other forms of hereditary neuropathies which either affect sensory fibers or autonomic fibers or one of those fibers, and then there are other rare conditions that are listed there. The hereditary neuropathies typically can start insidiously. They are sometimes much more slowly progressive than the other acquired conditions I have mentioned. In patients, for example, who have Charcot-Marie-Tooth, it's not uncommon that these patients have either high arches or flat feet and hematoes, and that sometimes runs in the family and can be seen in generation to generation transmission. The diagnosis of these conditions is by history, examination, gene testing if those genes are available commercially, and sometimes we end up examining relatives of the affected patient who we suspect have a genetic neuropathy, and sometimes that is helpful to make this diagnosis. As I said, there are substantial number of neuropathies that we could not classify under one of the groups that I have previously mentioned, and they are labeled as idiopathic and cryptogenic. The experience with these neuropathies is that they are slowly progressive, they are not life-threatening, and the disability caused by them occurs over a long period of time. Sometimes it takes 10, 20, 30 years for these neuropathies to cause significant cumulative disability. And that is not an uncommon reason for patients to seek multiple neurological opinions because they are concerned about the cause of neuropathic disease. I would like to emphasize a point. In vast majority of patients who have such neuropathies, it is not indicated that they should undergo nerve biopsy. So the principles of treatment include specific treatment for underlying disorders, and this is easy for patients who have specific infections, or if patients who have deficiency states, one can actually replete them if that's possible. If patients have toxic neuropathy, removing the toxin at least can prevent progression of the disease. Sometimes it does not help. reversal or complete repair of the nerve. Then for immune neuropathies, there are a large number of medications that we use, but the three that are used most commonly include steroids, IVIG, and plasma exchange. Then symptomatic treatments include pain management, management of the autonomic symptoms, management of gait and stability issues, and there are large number of devices, both that help the gait and ambulation, and there are a large number of devices that can help in the kitchen, in the toilet, that improves quality of life, that can be accessed through the occupational therapist. And foot care, as we have discussed previously in the context of diabetes, is extremely important in all patients who have neuropathic disorders. So, as we are running out of the time, I'm just gonna briefly touch on pain, and then I'll take the questions. We already have a few questions. Pain is a complex phenomenon, and it involves abnormal function of the pain fibers in the peripheral nerve, but then abnormal connectivity develops along other areas of the nervous system, particularly at the level of spinal cord and more rostrally around thalamus and brain. So sometimes even if a neuropathic condition goes away, for example, if a toxic neuropathy is treated and the patient does not have ongoing nerve injury, they can be left with chronic pain, although the nerve itself is not undergoing injury, and that is because of this abnormal connectivity that is shown on the right side of the diagram. So, just to emphasize that fluctuations are extremely common in neuropathic pain, and any kind of emotional or physical stress aggravates neuropathic pain. Good sleep hygiene, physical therapy, psychological counseling, all are helpful in the management of pain. This slide here lists medications which have been tried for management of neuropathic pain, and drugs that have these asterisks or stars in front of them have been shown in prospective clinical trials to be efficacious in the management of pain. They really belong to three different groups of medications. These are antidepressants, anti-epileptics, and then narcotic analgesics. There are interventional therapies for neuropathic pain that include nerve blocks, intrathecal pumps, spinal cord stimulators, sympathectomy, and they are required or used in patients who are unresponsive to medical management. Then the neuropathic pain tends to burn out in a proportion of patients, and this study here in nutshell shows that in about 1/5 of patients over 5 years the pain tends to burn out. So for some patients there is hope. As the neuropathic process progresses, there is termination of pain. There are a lot of interest in developing new neuropathic interventions to help both repair the nerve and to manage the pain. Both industry and academia are involved in this. Our group actually is also interested in that, and we recently have published use of erythropoietin, which is a growth factor that we have shown experimentally helps to enhance nerve repair. This slide here lists different patient support groups which are very active to educate and guide patients who have different neuropathic disease, and you can actually search them on the internet. And then I'm going to stop here and take questions at this point. The first question is, how effective is acupuncture in treating neuropathy? This I get asked this question not infrequently in the clinic about use of acupuncture. So I typically encourage patients who are not responsive to traditional treatments of neuropathic pain that they should try it, and in some patients it is quite effective in alleviating their pain. So I haven't actually really gone through the pain management in detail, but clearly in treatment trials for neuropathic pain, there is interestingly a significant placebo effect in patients who in these trials receive the active drug, and then there's a group that receive placebo. The placebo group actually have shown a fair amount of improvement in their pain in clinical trials. So therefore, any intervention is better than no intervention. So I think I encourage people to try alternative interventions for which we are quite certain that there are no long-term long-term or short-term deleterious effects, and acupuncture happens to be one of them. And in patients who don't actually respond to traditional interventions, it's okay to try acupuncture. So the next question is, I take Lyrica and Cymbalta for diabetic neuropathy, helps with pain. However, I walk like a drunk soldier and my ankles become weak and can hardly walk any distance. Any suggestions so that I can walk better? So I think I'm not sure actually what exact regimen that you take of Cymbalta and Lyrica, but there are things that can be done. You could be taking most of the Lyrica and Cymbalta at bedtime rather than in the morning, and so you could be taking less amounts of Lyrica in the morning and the afternoon, but majority of your dose can be at bedtime. Then Cymbalta you could be taking just at bedtime if it doesn't affect your sleep. In rare patient, if you take Cymbalta at bedtime, it actually can cause sleeplessness. So depending upon your situation, it could be, if you tolerate it, be taken at bedtime, and that sometimes help to decrease the drowsiness and dizziness and imbalance that comes with combining more than one psychotropic medication. The next question is, if I am diabetic, will changing my diet help with the pain associated with peripheral neuropathy? So I think changing your diet is a good thing. As I said, glycemic control can help retard the progression of neuropathic disease in patients who have diabetes. In a small minority of patients, if there is tight regulation of blood glucose related to diet manipulation, there is improvement in pain scores and pain. So yes, I think it's worth trying it. The next question is, what about recovery from pernicious anemia? So in patients who have pernicious anemia, they typically develop vitamin B12 deficiency and associated spinal cord and peripheral nerve disease. So I'm not sure actually what syndrome do you have, but vitamin B12 depletion in this condition, it certainly arrests progression of the disease. In some patients there is improvement and reversal, but in some patients they do not actually get back to baseline and are left with residual damage that is not repaired by vitamin B12 repletion. Here is a note from Neuropathy Association. I'll read it. Actually, this is from their president. She says that please let participants know that the Neuropathy Association can help with additional information and resources for patients and professionals for all types of neuropathy and neuropathic pain. Their website address is www.neuropathy.org. Thank you so much. The question is, I have tingling toes, no pain, take B vitamin and do electrical stimulation physical therapy. So I think it sounds like that you do have a neuropathic disease, so you just want to watch out for which B vitamins do you take. As I said, too much of B6 can be bad, and I typically recommend no more than 25 milligrams a day. So if you're taking more than that of B6, you tend to alter that. Otherwise, you can take other B vitamins, and they don't have toxicity associated that aggravates neuropathic condition. The question is, do you recommend any other home remedies for treatment of pain? So I think anything that helps. Sometimes wrapping the feet in warm or cold soaks helps. Sometimes if the pain is more proximal, using rubs, topical rubs can help. But please be mindful. In most neuropathic patients who do have sensory neuropathy, there is loss or impairment of protective sensations. So if you are using warm soaks, or if you're using a hot water bottle, be very careful. You can actually get injured, or you can actually burn yourself without really realizing it. So the gentle physical exercises at homes is not a bad thing to do. Water therapy, or if you have a pool at home, then non-weight bearing, gentle swimming is also not bad at home. The question is, how effective are pain pills treating neuropathy? So in most patients who have neuropathic pain, finding pain relief is possible. So one of our goals of treating pain is not to eliminate it, but make it bearable. And if one persists for a period of time, then the treating physicians can find either a single medication or a combination therapy where they use more than one medication that provides some relief in pain. Some patients are resistant to pain management with medications. As I said, those patients are candidate for a little bit more invasive interventions, as nerve blocks or intrathecal pumps, or use of spinal cord stimulators. But as I said, in most people we can make a dent in their pain. But if the pain is very mild, it's helped by over-the-counter medications, then you do not have to take the medications we typically use for neuropathic pain, because all of these medications have side effects. I consider these medications as our allies. They have really their moods and side effects, so they bring in both good and bad to the table. So we use them when we have to, and I use them liberally. But if the pain is mild and if simple medications which are over the counter help your pain, then you don't need to use these pills which can have potential side effects. Physical therapy is helpful. It has to be tailored according to the type and severity of your neuropathic disease. Physical therapy helps actually you to be limber, It helps actually keep the tone of the muscle. It can delay the atrophy associated with motor neuropathy, and it also can help the sleep hygiene, which can then even affect the neuropathic pain. So I think physical therapy has lots of benefits. If you have a lot of sensory neuropathy, particularly painful that affects your feet, then it is not a bad idea to avoid high impact exercises because they can accelerate damage to the bones in the feet and can accelerate the development of Charcot joint. So low impact or non-weight bearing exercises such as getting on a bike or swimming is more helpful in those situations where you are at risk of developing Charcot joints. So I think you should develop an exercise regimen in consultation with your physical therapist or with your physician that best suits your needs. So I think it's 1 o'clock and I'm going to stop here. Thank you everyone for participating in this webinar. This webinar is recorded and archived, and a link to this webinar I think will be forwarded to all the registrants of this webinar. Thanks. Bye.